Hi everyone, my name is James Rose and I'm here to speak with you all about BK virus associated nephropathy. BK virus, also called BKV for short, is a double-stranded DNA virus belonging to the family Polyomaviridae. In general, there's not a whole lot known about this virus in particular, unfortunately. It was, however, first discovered in 1971. The initials of the first patient associated with this virus, BK, gives the virus its name. Nonetheless, it is an opportunistic pathogen as the virus causes disease in renal transplant patients, ultimately causing BKV-associated nephropathy. In a nutshell, the virus, which is sequestered in tubular epithelial cells within the kidney itself, has the ability to cause tissue damage in immunocompromised hosts. Currently, there is no specific treatment for BKV infection. However, treatments involving tissue graft immunosuppression is of use. This is so that the patient can survive the kidney transplant so that the virus can run its course. Infection with BKV depends on the patient's immunostatus. This presents differently if the host is immunocompetent versus immunocompromised. This virus has a worldwide distribution of up to 80%. What that means is that the majority of the world's population has already been exposed to this virus at some point in their lives. There's even a good chance that the majority of the people within our class have been exposed. Fortunately, disease will not occur since the majority of our class I would expect to be immunocompetent. In most cases, the virus infects the host, and after a brief cold and flu-like symptoms, life goes on. However, if the host becomes immunocompromised, as commonly seen in kidney transplant recipients, disease presentation can occur. The ultimate complication of BKV in these recipients is its associated nephropathy. In other words, kidney tissue damage from viral replication going unchecked by the host immune system. Up to 20% of renal transplant recipients develop viremia within 1 year of the procedure being done. This is the primary risk factor. Typically, these patients are monitored post-renal transplantation with either urine or plasma screening tests. This is called the viral load, and just as the name suggests, it quantifies the amount of virus within a patient sample. A viral load can be performed, in a sense, on any virus. This procedure is commonly performed on other pathogens as well, such as HIV, hepatitis, or even CMV, which is another pathogen for renal transplant recipients. The molecular method of choice for BKV analysis is the quantitative real-time polymerase chain reaction, real-time qPCR for short. The first FDA-approved PCR assay for this pathogen occurred back in 2020. This means that prior to that year, all clinical assays used to detect BKV viral particles occurred as a laboratory-developed test. This means that the protocol for running such tests varies from laboratory to laboratory. If the viral load suggests infection, follow-up testing can include a kidney biopsy, which is used to detect the possible kidney damage associated with the virus. I will now go over the steps for this chemical reaction quickly. As with the majority of PCR, there are 3 basic steps. These include extraction, amplification, and product analysis. Once the nucleic acid has been purified, these extracts are placed inside PCR reaction tubes, shown on the right, along with its master mix. The components of the master mix, such as primers and probes, along with buffers, are specific to BKV viral sequences. What makes real-time PCR unique is that the products of the chemical reaction, in other words, the fluorescence, is visualized as the assay is running. Once the fluorescence passes a certain threshold, a positive reaction can be determined. The reaction intensity is compared with a calibration curve or a standard curve, and this measurement is directly translated to the quantity of the virus. The article featured in this presentation is called BK Polyomavirus Infection After Renal Transplantation, Surveillance in a Resource Challenge Setting, published back in 2017. I believe that the study does an excellent job at correlating the viral load with the presentation of disease in this otherwise vastly unknown pathogen. This article sheds light on BKV surveillance in underdeveloped India and the incidence of viral infection associated with respective kidney damage. This also emphasizes the timeline of the disease process. In short, the study follows a cohort of 62 post-kidney transplant recipients with 5 periodic plasma viral load measurements. These were taken at 1, 3, 6, 9, and 12 months from the day of surgery. The results of this study would not be possible, again, without quantitative real-time PCR. This is the primary tool for generating almost any data about this virus at the clinical level. This makes the viral load key. As explained on the previous slide, the image above depicts a larger fluorescent signal directly translating to more copies of the viral material within the sample. Pictured right next to it is an example of the type of instruments utilized within the study. This includes a thermal cycler and its computer, which measures and interprets the fluorescent signal. This is the direct clinical application of this technique, measuring the amount of virus in the respective plasma sample. The unit of measurement is copies per mil. Viral loads were determined through commercially prepared master mixes, as is quite commonly performed in hospitals as well as most reference laboratories. The results of the study put its subjects in different groups. First, viremia is detected as detecting any amount of virus in the sample. For the purposes of this study, viremia is defined as 500 to 9,999 copies per mil. Significant viremia would be greater than 100,000 copies per mil, even more. Sustained significant viremia would be greater than 10,000 copies measured on 2 separate occasions. The results of the study are as follows. 40 out of 62 patients developed infection with BKV, which is almost 2/3. 20 subjects, roughly 1/3 of the total, developed significant viremia. 9 subjects out of 62, about 14%, had sustained significant viremia. Lastly, 3 patients developed BK virus-associated nephropathy. It is important to note that these 3 patients had sustained significant viremia. The interpretation of the data is as follows. The majority of patients who received kidney transplants developed a BKV infection within 1 year due to host immunosuppression. An interesting note is that the majority of patients who had detectable viremia had the highest viral load between 3 and 6 months post-transplant date. Ultimately, kidney tissue damage and dysfunction, which is the nephropathy, occurred in 0.5% of cases. The future direction, well, there are some things to think about with this study and the limitations that preside. Although 62% is the cohort size, it is still relatively small, as more data can be generated with a larger group. Moreover, the researchers mentioned an excellent point. The BKV status of kidney donors were not evaluated at all. In addition, additional studies on targeted treatment against BKV is warranted in the realm of antiviral development. Let's go ahead and wrap up and review the main points of BK virus. This pathogen is an opportunistic virus that can become activated in the immunosuppression of renal transplant recipients. As far as molecular methodology goes, quantitative real-time PCR is the ultimate diagnostic tool in managing infections with BK virus. Unfortunately, that leaves much to be discovered on the molecular level other than simply knowing that this virus exists. Thank you very much for your time.